is the growth hormone and the IGF-1 axis. The GHRH is produced via the hypothalamus, which then regulates via the GHRH receptor the production of growth hormone. Growth hormone secretion is also controlled or modulated by other factors like somatostatin, and then this growth hormone is also produced along with growth hormone binding protein. It then circulates with the growth hormone binding protein to reach its target receptor. What is unique about this growth hormone binding protein? What exactly is the growth hormone binding protein?
The extracellular domain of the
yes.
And what it does, it maintains the growth hormone level in the body. And there is less variability in the...
Is it just a binding protein or does it do beyond that? Yes. So, yeah, binding protein is there for transport, but it is a targeted transport. You can talk it like a chaperone. So, once it binds, it will take the growth hormone to the site of action. And what else it will do? Will the half-life of growth hormone increase? So, in conditions where you have got increased amount of growth hormone and growth hormone binding protein, your half-life will be more. You will have more effect of growth hormone. While if GHBP level is low, your effect of growth hormone will be of shorter duration and the direction will be less. So theoretically, if you treat somebody with growth hormone alone versus GH plus GHBP3, the GHBP1 will do better. But there are not much studies because it's not very easy to do in that regard. So it's not just a simple binding protein, it is also a carrier. And this is unique. So which hormones usually have a binding protein? So peptides have, not the steroids. So steroids, peptides don't need. Peptides basically, will they travel in blood easily or not? So they don't really need a binding protein. So when you have IGF-BP3 or you have GHBP, these are strange, unique things. PTH doesn't have a this thing, FSH, LH, none of them. So it's basically cortisol binding globulin, thyroxine binding globulin, or whatever, it's mainly steroids. So there are two unique hormones, peptide hormones, which have a binding protein, the growth hormone binding protein and the IGF binding protein. Their action is more to modulate the action and guide their action. IGF-BP3 will not let IGF-1 levels to go really up. So if your free IGF-1 goes really up, you may have risk of malignancy. So that's why it sequestrates it for a certain scenario. So now it acts on the liver to produce two important compounds, IGF-1, IGF-BP, and also acid labile substrate, which is ALS, and all three of them will travel in the circulation. And this IGF-BP is now, as I said, is another peptide binding protein, which then carries it to its site of action. The most important site there would be the growth plate, where it will act on the IGF-1 receptor to cause induction of growth, largely the sulfation of the chondroitin. So earlier studies were all about how fast in this chondrocyte the chondroitin is sulfated. That's why this factor of sulfation factor came in. Then people found that this also causes hypoglycemia. And that's why they realized that it acts on the insulin receptor, and that's why it was called as insulin-like growth factor. So the IGF system we talked about is IGF-1, IGF-BP3, and acid labile substrate. All three of them are important. This ternary complex goes in a compound. They walk around, and IGF-1 will act on the type 1 IGF receptor. This is not IGF-1 receptor. It's a type 1 IGF-1 receptor, which causes cellular growth and prevention of apoptosis. This is the large thing, and also differentiation of cells. Now, IGF-2 is also produced, but IGF-2 is more of a local agent rather than a systemic agent. It also has some effect on the type 1 IGF receptor. There is also another important receptor, which is the insulin receptor, and insulin is the primary mediator. And we discussed about this when we were discussing about various forms of genetic diabetes, that this receptor will cause main effect on glucose, but there is also overlapping effect on growth. So this will cause glycogenolysis, this will inhibition of ketogenesis and anabolism, but there is an effect on growth as well. Now, IGF-1 can also act on the insulin receptor, causing hypoglycemia. IGF-2, the main receptor, is type 2 IGF receptor, which actually suppresses growth. So it's like a modulator. If you're growing too much, this IGF-2 will switch off this growth. So if your IGF-2 activity is enhanced or suppressed, you will have different growth disorders. And there are two groups of disorders which are associated with IGF-2 excess and deficiency, and both are imprinted. So which one are we talking about? Opposite of it is Beckwith treatment. So these are the disorders in which IGF-2 is over or underexpressed, which is going to cause a problem there. Now, IGF-1 does not bind to the type 2 IGF receptor. So its main role is in terms of the action. Insulin has a 5% action on the type 1 IGF receptor, so it will also cause some growth, which is going to happen. It doesn't affect the type 2 IGF receptor. So IGF-1 levels are low to begin with. In the first 2 years, the levels are very low. So do not measure IGF-1 before 2 to 5 years of age. It's of a limited role. Levels are hugely varying. So if you see in puberty, see what's the range. This is normal. This is also normal. So all that thing that we talk about, most data of IGF-1 is very, very limited. 50, 60 patients per group. So you can't really rely that this is a very perfect data. So whenever you're looking at IGF-1, look at it with a pinch of salt. Second, IGF-1 is affected by malnutrition, via liver disease. So if you have a low level, you cannot say that it's always IGF deficiency. Now, IGF-1 is transported, as I said, this is again a unique hormone, a unique peptide hormone that it is bound via the IGF-BP3, which modulates its interaction and increases the half-life and carries it towards the type 1 IGF receptor. If you have a IGF-BP3 deficiency, you will have too much IGF-1 for some time. So it may cause more risk of malignancy, but then the levels will go off. So there will be a problem which happens from that regards. So IGF bonding protein, there are multiple IGF binding proteins in different regions. So BP3 is the predominant circulatory one. There are BP1, BP2, then BP3, BP2 is predominantly the tissue one, especially in the CNS, it becomes important. BP3 is circulatory, 5 is local. So what all they do is that they don't allow this IGF-1 to escape. When we talk about endocrine versus paracrine, we say that endocrine goes in the blood and works, paracrine is the local area. So these binding proteins, they have a different role. The endocrine binding proteins are carrying you from one place to the other. In the paracrine system, they are not allowing you to go off. So if you have IGF-1 in a local feed system, it will bind it here and just allow it to be in that regards. So these proteins also have specific effectors and they allow the tissue specific effect of IGF-1 and they have variations. So IGF-1 receptors, I said you have got type 1, type 2 and insulin. IGF-1 has the highest affinity for type 1 receptor. IGF-2, of course, for both type 1 and type 2 receptors, and insulin largely for insulin with a partial one for type 1. The second messenger for type 1 is MAP kinase, which means mainly growth. For insulin is PI3 kinase, which mainly means the glucose metabolism. Hypoglycemic effect is highest, of course, for insulin. The mitogenic effect is highest for the type 1 IGF receptor. Now, IGF-1, how does it act? So I've discussed that this is actually a tyrosine kinase. You've got external rotation, alpha subunit and the beta subunit, just like insulin. And then you have an intrinsic tyrosine kinase. Binding of IGF-1 to its receptor will cause approximation. While in the growth hormone, we said that they came close and then they will separate. Here, they will bring together and this tyrosine kinase will now become active. It will cause phosphorylation, producing IRS1 and 2 and PI3 kinase PKC, causing glucose transport. SHC will become active and you have got the RAS pathway, the MAP kinase pathway. As discussed in the last class, insulin will mainly work towards the glucose pathway with a partial effect on the metabolic and the growth pathway. This will work mainly for the MAP kinase and the mitogenesis pathway as well as anti-apoptotic pathway. So it will block apoptosis in that regards. So this understanding of growth hormone, IGF-1, IGF-2 action has largely come from rodent knockouts. So what you will do is that you will have a knockout for growth hormone receptor. You will have a knockout for IGF-1, IGF-2, IGF receptor, type 2 IGF receptor, and then you will see what happens in that regard. So if you knock out growth hormone, we know that the birth size is normal. Okay, so sorry for the confusion. So if you have a knockout at the level of growth hormone, your birth size will be normal, but postnatal growth will be affected. This is all we always talk about. If you have a problem on the growth hormone receptor, what will happen? Again, the same thing. Because the birth growth antenatally is unaffected by growth hormone. And IGF1, however, if you delete, you will have 60% of birth size. So 40% of growth, you can say, is working via the IGF1. If you delete IGF2, again 60% birth size will be less, and the most severe form will be Russell-Silver syndrome. If you, however, knock out IGF1, IGF2, and type 1 IGF receptor, you are totally gone, 30% on this side. So somebody was 50 centimeters will become 15 centimeters. While there it was 60% will mean 30 centimeters. And if you knock out IGF1 receptor, there is 45% growth. And if you knock out IGF2 receptor, you have got more growth. So what does it mean? That the type 2 IGF receptor is actually suppressing growth, while type 1 IGF receptor is increasing growth. And there are receptor independent effects also which are there. So based upon this, people brought out all this concept of what IGF1 does, what IGF2 do in that regard. So to summarize the effect of growth hormone hormone and the entire axis, you have got the growth hormone which acts on the growth hormone receptor to produce IGF1, which acts on the IGF1 receptor to increase the growth of proliferative phase. Then you will also have increased numbers. Growth hormone has a direct effect also on the growth hormone receptor to produce IGF1. It also produces BMP, which causes the growth of the collagen 2 as well in that regards. So overall, it has an increased growth and an anti-apoptotic effect. Now, growth hormone IGF1, we already discussed. This IGF1 will bind to the IGF1 receptor, or it will be more precise to say a type 1 IGF receptor. Why I am saying type 1 IGF receptor is that IGF1, insulin, and a bit of IGF2 also binds to that receptor. And binding to that receptor, it will cause increased growth. Growth hormone, however, will also have multiple other effects. It's going to act on the adipocyte to cause lipolysis. That's why individuals who have growth hormone deficiency look plump. They have central obesity, they have got round faces and all the other features of fatty excess. It also has an effect on the kidney. What are the major effects of growth hormone on the kidneys? What do you need for growth? And what grows when you're growing? When you're growing, you need what? You're saying bone is growing, so you need what? And phosphorus. So calcium also, if you really look into that, growth hormone, prolactin, and estrogen increase the calcium absorption from the gut. But in the kidneys, growth hormone has a very specific effect of increasing phosphorus absorption. That is why people have used growth hormone in hypophosphatemic rickets, not only to increase growth, but also to increase phosphorus retention. So it's going to cause effect on phosphorus. It's going to have a direct effect on the bone as well, which is independent of the IGF1. And it is going to affect the liver also to have an effect in terms of glucose levels will go up. So you will have hyperglycemia. So when you talk about treatment with IGF1 versus treatment with growth hormone, which one will be better? Why?
Pathway of IGF1, apart from this, there is also a pathway that is directly acting on the.
So growth hormone is having many other effects. It's also increasing IGF-BP. So because of IGF-BP, your free IGF-1 will not go up. Half-life will go up, so the effect will be more. Second, this is causing hyperglycemia. IGF-1 will cause hypoglycemia, which becomes important. Plus, there is also a paracrine effect on the bone as well. So whenever you have got a growth problem and you have option of treating with growth hormone or IGF1, growth hormone is the treatment of choice. The only indication for IGF1 treatment is if you have GHD type 1A, wherein you have got antibodies which have developed against growth hormone, which is not working. And second, of course, is genetically proven growth hormone insensitivity. That's the only role of IGF1. People used to say that IGF1 would be a better agent. So why don't you use the distal agent rather than growth hormone? But now growth hormone has been found to be more versatile in terms of action which is there. So as I said, growth hormone will have an effect on IGF1, and this IGF1 will cause hypoglycemia.